I just want to show this table so that we can really appreciate the link between the gallstones and the syndromes it causes. This is a typical example of pathology. Gallstone is definitely a pathological state. But there are so many pathological states in patients that do not have clinical significance. They do not manifest clinically. They exist only as a silent pathological state. And one of them is gallstones. You know, if they are small or even if they are big and they don't cause the blockage in the neck and they just floating around in the gallbladder every time a person take their meal, they will not cause any clinical condition. But once they get stuck in the neck or they start travel down the biliary system, this is where there's a progression of a simple gallstone into the clinical syndrome. You know, we have described in the diagrammatic fashion just now, but now I just want to describe it in a table form so that we can see where all these relationships are. And I include here asymptomatic subclinical gallstone as one of the uncomplicated gallstones. This is all a theoretical concept in our mind. We may not see this group of patients because they are asymptomatic. We usually see biliary colic and acute cholecystitis patients. So these are early stage, if you can call it stage. There's no staging system in gallstone syndrome, but you can tell it to your own mind. This early stage. And patient might ask you, doctor, is this early stage? Doctor, the patient do not distinguish whether it is malignant condition or benign condition in order to ask what stage they are in. They might ask you what stage they are in. You can say this is an early stage and we can manage you in the clinic without referring to the hospital. So once you refer to the hospital, you can do a few things before patient really go to the hospital. I see quite often patients are kept near by mouth. No, in a patient with gallstone, whatever syndromes they have, they can still take clear fluids. It will not impact so much of the symptoms because the biliary system will respond to food material like lipids and carbohydrates. So patient can continue to take clear fluids. And this clear fluid is not merely just mineral water. They can take isotonic drink or even Coke if they like it. It can give some energy. Just avoid milk and similar products. Continue taking their own medication. Whatever they're taking, antihypertensive, they should take. You have to stop some medication like anti-diabetic since they are not taking any glucose in, so they have to stop their anti-diabetic treatment. And if they are on blood thinners, many patients are on blood thinners because of the ischemic heart disease. You have to stop them immediately before going to the hospital. And then you can give them painkillers in the form of antispasmodic in the clinic before going out to the hospital, and even PPI or even oral antibiotics that they were taking. They can continue taking them on the way to the hospital. Just avoid a stronger parenteral painkiller like opiates and NSAID. This is what we do in the hospital when the complex gallstone patient are admitted from the clinic. You can see this is a very highly intensive, highly resource management of this patient, befitting only a tertiary center actually. But in some secondary setup like our place, when there are multiple specialties that are helping one another in managing this complex patient, we can manage this patient. But it is a very stressful, labor intensive. You can imagine to manage this kind of patient in the tertiary center setup. There are rank and file of doctors from housemen, medical officers, registrars, and consultants. But in the private setup, you can imagine the consultant will function as a registrar, as a medical officer, as a houseman even. So that's why many general surgeons stop doing cholecystectomies in the secondary specialist hospital setup because of this intensity of resource.